this video is to explain the ALS algorithm.
Mr. Smith? Mr. Smith? Mr. Smith, are you okay?
If we find an unconscious patient, first thing to do is to check for signs of life, breathing and pulse. You can do it simultaneously if trained to do so.
It's gasping.
If the patient has no signs of life, call the resuscitation team. Perform uninterrupted chest compressions while applying self-adhesive defibrillation monitoring pads. One below the right clavicle and the other in the V6 position in the mid-axillary line. Plan actions before pausing CPR for rhythm analysis and communicate these to the team. Stop chest compressions not longer than 2 seconds to check rhythm. Resume chest compressions immediately. If the rhythm is VF or pulseless VT, one member of the team should select the appropriate energy on the defibrillator. 150 to 200 joules biphasic for the first shock, and press the charge button. While the defibrillator is charging, warn the rest of the team other than the one who is performing chest compressions to stand clear and remove any oxygen delivery device. Once the defibrillator is charged, tell the rescuer doing the chest compressions to stand clear. When clear, give the shock. Without reassessing the rhythm or feeling for a pulse, restart CPR using a ratio of 32, starting with chest compressions. Continue CPR for 2 minutes. The team leader prepares the team for the next pause in CPR. Pause briefly to check the monitor. If VF or pulseless VT, deliver a second shock. If after 2 more minutes, VF or pulseless VT persists, deliver a third shock. Without reassessing the rhythm or feeling for a pulse, resume CPR 32 immediately after the shock, starting with chest compressions. If intravenous or intraosseous access has been obtained, during the next 2 minutes of CPR give adrenaline 1 mg and amiodarone 300 mg. Give further adrenaline 1 mg intravenous after alternate shocks. In practice, this will be about once every 2 cycles of the algorithm. The use of waveform capnography may enable recovery of spontaneous circulation to be detected without pausing chest compressions. It may be used as a way of avoiding a bolus injection of adrenaline after recovery of spontaneous circulation has been achieved. If recovery of spontaneous circulation is suspected during CPR, withhold adrenaline. If signs of life like purposeful movements, normal breathing or coughing, return during CPR, or there is a significant increase in EtCO2, check the monitor. If organized electrical activity compatible with a cardiac output is seen during a rhythm check, seek evidence of recovery of spontaneous circulation. Check a central pulse and end-tidal EtCO2 trace if available. If there is evidence of recovery of spontaneous circulation, start post-resuscitation care. If no signs of recovery of spontaneous circulation, continue CPR and switch to the non-shockable algorithm. If asystole is confirmed during a rhythm check, continue CPR and switch to the non-shockable algorithm. If after applying self-adhesive pads and check the rhythm, a non-shockable rhythm is displayed, start CPR 32. If asystole is displayed, without stopping CPR, check that the leads are attached correctly. Once an advanced airway has been sighted, continue chest compressions without pausing during ventilation. Give adrenaline 1 mg as soon as venous or intraosseous access is achieved, and repeat every alternate CPR cycle. That means every 3 to 5 minutes. After 2 minutes of CPR, recheck the rhythm. If asystole is present, resume CPR immediately. If an organized rhythm is present, attempt to palpate a pulse. If a pulse and or signs of life are present, start post-resuscitation care. If no pulse and or no signs of life are present, PEA, continue CPR and recheck the rhythm after 2 minutes. Give further adrenaline 1 milligram for every 3 to 5 minutes, during alternate 2-minute cycles of CPR. If asystole or an agonal rhythm is seen at rhythm check, continue CPR. Recheck the rhythm after 2 minutes. Give further adrenaline 1 milligram for every 3 to 5 minutes, during alternate 2-minute cycles of CPR. If VF or pulseless VT is observed at rhythm check, change to shockable side of algorithm. Whenever a diagnosis of asystole is made, check the ECG carefully for the presence of P waves, because this may respond to cardiac pacing. There is no benefit in attempting to pace through asystole. During the treatment of persistent VF or pulseless VT or P and asystole, emphasis is placed on high-quality chest compressions between defibrillation attempts, recognizing and treating reversible causes, 4Hs and 4Ts, obtaining a secure airway, and vascular access. Reversible causes are potential causes or aggravating factors for which specific treatment exists must be considered during any cardiac arrest. For ease of memory, these are divided into 2 groups of 4 based upon their initial letter, H or T. Hypoxia. Minimize the risk of hypoxia by ensuring that the patient's lungs are ventilated adequately with 100% oxygen. Hypovolemia is due usually to severe hemorrhage. Intravascular volume should be restored rapidly with fluid and blood, coupled with urgent surgery to stop the hemorrhage. Hypokalemia, hypokalemia, hypoglycemia, hypocalcemia, and other metabolic disorders are detected by biochemical tests or suggested by the patient's medical history. Hypothermia. Suspect hypothermia in any drowning incident. Use a low-reading thermometer. Tension pneumothorax. The diagnosis is made clinically. Decompress rapidly by needle thoracentesis and then insert a chest drain. Cardiac tamponade is difficult to diagnose. Cardiac arrest after penetrating chest trauma or cardiac surgery should raise suspicion of tamponade. Consider the need for needle pericardiocentesis. Toxins. Where available, the appropriate antidotes should be used, but most often the required treatment is supportive. Thrombosis. Pulmonary embolism or coronary thrombosis. If pulmonary embolism is thought to be the cause of cardiac arrest, consider giving a thrombolytic drug immediately. So, remember, if any reversible cause is present, survival following cardiac arrest is unlikely unless it is recognized and treated. Tracheal intubation provides the most reliable airway, but should be attempted only if the healthcare provider is properly trained and has regular, ongoing experience with the technique. Tracheal intubation must not delay defibrillation attempts. Personnel skilled in advanced airway management should attempt laryngoscopy and intubation without stopping chest compressions. No studies have shown that tracheal intubation increases survival after cardiac arrest. Ventilate the lungs at 10 breaths per minute. Do not hyperventilate the patient. Once the patient's trachea has been intubated, continue chest compressions at a rate of 100 to 120 per minute. In the absence of personnel skilled in tracheal intubation, a supraglottic airway is an acceptable alternative. Get a peripheral venous access if this has not been done already. Drugs injected peripherally must be followed by a flush of at least 20 milliliters of fluid and elevation of the extremity for 10 to 20 seconds to facilitate drug delivery to the central circulation. If intravenous access cannot be established within the first 2 minutes of resuscitation, consider gaining intraosseous access. The drugs used in cardiac arrest, including adrenaline and amiodarone, can be infused by an intranosseous access. Fluids and blood products can also be delivered, but pressure will be needed to achieve reasonable flow rates. Any question? So remember, heart rhythms associated with cardiac arrest are divided into 2 groups: shockable rhythms, ventricular fibrillation and pulseless ventricular tachycardia, and non-shockable rhythms, asystole and pulseless electrical activity. difference in the management of these two groups of arrhythmias is the need for attempted defibrillation in patients with VF or pulseless VT. In case of shockable rhythms, give a shock and perform high-quality CPR for 2 minutes. Minimize interruptions. After 2 minutes, check the rhythm and if VF is still present, give another shock. After 3 shocks, give adrenaline 1 mg and amiodarone 300 mg. If case of non-shockable rhythm, perform high-quality chest compressions minimizing interruptions and give adrenaline as soon as you get a vascular access. Check the rhythm every 2 minutes. In both cases, once adrenaline is given, repeat every 2 cycles of 2 minutes unless recovery of spontaneous circulation is achieved. Give oxygen when ventilate, and if available, use waveform capnography. If recovery of spontaneous circulation is achieved, start post-cardiac arrest treatment. Always think about reversible causes and treat them if present. Consider ultrasound imaging, mechanical chest compressions, percutaneous coronary intervention, and extracorporeal CPR.